Well, I couldn't have asked for a better segue into our next presentation, which is talking about the Healthcare Coalition as a response support. Before I do that, because again, we have so many new faces in the room today, and I don't know you well enough to know your backgrounds and how much you understand this kind of weird language that we're speaking, I want to talk about just a few of the acronyms that we've been throwing around today. So one of them is ASPR. I mentioned this really briefly during our accomplishments presentation. I can't remember if it's associate or assistant, whatever. It's A, associate? Assistant Secretary of Preparedness and Response. This is the federal office that funds healthcare coalitions and the work that we do. They are the people who give us guidance on what our activities should be. They are the people to whom we report. We want to be on their good side, and we want to have really good communications with them. When we talk about ASPR equipment, like they showed the picture of the ASPR tent, that's an ASPR tent. So with some of our grant funds over the years, we've purchased a fair amount of equipment, decontamination equipment, tents, alternate care facility trailers, ventilators, and various other durable medical equipment resources. So we are happy when we get to use those. I mean, you know, no one wants the disaster. The fireman doesn't wish for fire, but then it happens, and so you get to do what you do. So, you know, it's kind of nice to show off that they were able to use an ASPR tent. So when we say ASPR, that's what we're talking about. It's the federal level of what we're doing. DMCC, Disaster Medical Coordination Center. Some people say Disaster Medical Control Center. It's a hospital. Each region in our state has a DMCC, a hospital who agrees to take on the role of helping with patient destination decisions from the scene of an emergency or disaster into the healthcare system. The goal of which being that we deliver the right amount or the right kind of patient care in the right amount of time at the right location. So we're not surging just into one hospital and overloading that system, then having to figure out how are we going to get people to where they can actually get care. So DMCC is a very important role in our state and nationwide, and Nancy and Katie alluded to their role being somewhat not as significant in their particular response, but still very important to have that capability. And the last one I wanted to mention is ESF 8. I won't talk about it too much right now because I'm going to talk about it during the presentation, but I wanted to just assure you if that's been rolling around in your head, like, what are they talking about ESFs? We're going to get to it in just a minute. So I'm going to talk about our Healthcare Coalition as a response support, and I'll ask for your patience a little bit. I want to speak very thoughtfully as I go through my presentation. When I talk about our accomplishments, I can sort of ramble on because that's actual work that I've done and that you've done, and it's in the past and I got it. But this is more like conceptual, so I don't want to screw up what I'm going to say. So sorry if I refer to my notes a lot. I just want to get it right. So we're going to talk about some tools to support the concept of the Healthcare Coalition as response support. So back to Jeff Ewing at Kootenai Health. It began with event request. Or did it begin with event request? Not really, but it's kind of a nice point in time that I like to refer to. So as a healthcare coalition, we'd sort of had this idea for a while. What would it look like if we functioned in more of a response support role as a healthcare coalition? And we kind of let that idea sort of ruminate for quite a while. We really started to think about this and feel about this as a way to really support not only our healthcare coalition members, but our entire healthcare community. We wish that every healthcare provider in Region 9 was connected with the Healthcare Coalition. But they aren't all, and it kind of doesn't matter because we want to help the whole healthcare system. So how can we help our whole healthcare system respond if there's an emergency? It sort of felt a little bit not aligned for us to help everybody prepare and plan and exercise, and we're all getting ready, and here we are. And then like it happens and we're like, whoa, hey, that sounds really tough. You know, good luck with that. So we thought we have to close the loop on being that support for our partners. We have to be able to offer some kind of response aspect to what they're actually going to be dealing with. And then with the DMCC concept, the Disaster Medical Control Center, we kind of had our toe dipped into that response role anyway, because DMCC is a response function. You're only going to activate DMCC when you have a bunch of people that you need to get into the medical system. So we were already sort of flirting with this idea of being a response agency, I guess, a response team, but we didn't really know where we were going to go with it. By bringing in some speakers to our coalition, we started to see some demonstrated support of this concept, some demonstrated success. So you might remember a few years ago, we brought in some speakers from Joplin, and they talked with us at length about their coordinated healthcare system response to the tornadoes that they experienced there. And again, Lori Upton from SETRAC, the Southeast Texas Regional Advisory Council. Another example of demonstrated success with a coalition-like organization functioning in a response role. So, you know, we're just sort of taking in all this information, looking at different models, and really letting it kind of slowly marinate in the background as we're doing a lot of the work that we talked about earlier. By attending the National Healthcare Coalition conferences over the past few years, again, we start to reinforce that idea. We're hearing about it more. We're learning about it more. It's becoming more, it seems more possible. And I really want to stress, this is not, for us, this is not a knee-jerk reaction. This isn't, we want to play too, we want to show up too. It's not about that. This is, we want to be in the background, we want to be supporting emergency management and healthcare providers if there is an emergency response. So we've taken a very methodical and slow approach to how we're going about this, how we're thinking about going about this. So we've developed some tools that we can use as a response structure, as a response support, I should say. I mentioned earlier that our hospital planning committee and our non-hospital work group worked really hard last year to develop a tool to help locate resources throughout our region. And we did this by first developing a survey of the types of durable medical equipment that we would want to ask about. So I've said it in previous meetings, and it is a bit of a joke, but we're not asking people how many gauze pads you have. We don't care. We're asking about big things. We're asking about bariatric stretchers. We're asking about surgical suites. We're asking about ventilators. And then we asked about some of the staff that various medical providers have on hand, everything from administrative staff to surgical staff. So what types of services, what type of experts do you have as part of your staff? And so this information was gathered in the form of a SurveyMonkey and compiled in an Access database that is now queryable so that we can locate those resources. You call the ESF8 desk and say you need a ventilator. We get some more specific information from you about that ventilator, and then we can query this database to try to connect whatever need you're having with the resources available in our region. We're really proud of having that tool available to us. As you heard a few minutes ago, it can be really difficult to know where the resources are and who to call to get them. So we're trying to do some of that work ahead of time so that we can be efficient during response and really get those needs met. We also conducted a volunteer survey. We wanted to understand how our members, how our healthcare system is planning to use emergency medical workers and volunteers during an emergency response. So with our volunteer survey, we were able to also share with those who took the survey some of the staffing resources available in our region, the Medical Reserve Corps, the Department of Emergency Management, registered volunteers, and other American Red Cross, other staffing resources that are available in our region, so we could use this also as an education tool. And so now with this survey, we have a pretty decent sense of who has a good procedure in place for bringing in emergency medical workers and staff, and who might need a helping hand if we do have a big medical surge event or just a localized emergency. Who might need that call in saying, hey, do you need us to send some volunteers your way? Okay, but then we really did have event requests. I've mentioned it twice, and it actually did happen. Jeff Ewing called, and I shouldn't say it was a request, it was an inquiry, but earlier this season we had a lot of respiratory illness, and there was a concern throughout the whole healthcare system that we might have a ventilator shortage. And so that initial call came in. Hey, how's it looking for ventilators? Do you have like any sitting under your desk? Do you know where I might be able to get some? It was just that initial inquiry. But it really started to validate then this concept of, can we be a response organization? Could we serve in this role? Here's somebody who thinks we can because he picked up the phone and called us. He's relying on the Healthcare Coalition, using his partner network to try to locate resources. So I think there's something here, and we should keep on talking about it. From that one simple call that Jeff Ewing made, inquiring about a ventilator, we then developed a pretty decent, simple medical resource request process. This was a tool that we shared with our whole membership, and if you don't have it and want it, I can certainly send it to you. Just outlining how do you get resource? Who do you call first? Who do you call next? Where do MOUs come into play? And when might you want to call the Healthcare Coalition? We just wanted to clarify that process for our members, so that if you did need to make that call of inquiry, you'd kind of have a good sense of how to go about it. All right, so as we explore this idea of being a response structure or a response agency, we really want to focus on only doing that for ESF8. And so now I find it necessary to back up a bit and talk about what are we talking about when we say ESF8. I don't know that everyone has a sense of that. I'm not going to ask you to raise your hand because everyone hates, like, no, I don't know what you're talking about. So I'll just assume you don't and give you a very brief overview. So nationally, we have a national response framework by which we are organizing our ideas about responses to emergencies. The National Response Framework is organized by ESFs. And here they are. There are 15 of them. I'm not going to read them all. There they are. So various disciplines fall into various ESFs. We sort of live in the realm of ESF8, Public Health and Medical Services. This is sort of the truncated title of ESF8 because, as Katie and Nancy mentioned, it's also mental health. It's also mortuary services. It's also veterinary services. There's a lot happening in ESF8, and there's some crossover with other ESFs. Does mental health really belong more in ESF6? Does veterinary really belong more in ESF11? There's some gray area between these, but we really want to make sure that we're focusing on our core public health, medical services, and mortuary services when we, as a coalition, think about what our response structure might look like. So we decided to start creating this ESF8 response resource manual. This is a tool to help support emergency managers and the healthcare system. And so why are we supporting emergency managers with this? Well, if you have an emergency today, you're going to call, I hope you know this, if you have like a really big emergency right now today and you need some stuff, you're going to call your Department of Emergency Management. I hope you have their 24/7 duty officer line or duty officer phone number in your plans. If you don't, let us know. But that's going to be a call that you definitely want to make, is to your Office of Emergency Management. We've got something going on. Emergency management's job is to help sort of organize all of the activities contained within these emergency support functions. So they're sort of the hub of the wheel of ESF. They're going to connect all of these various partners, whoever's needed for that particular emergency, to try to get those resources in place. But if you make that call to emergency, like, okay, so back to this list. Sorry, don't get nauseated, but this is a long list of a lot of stuff, and emergency managers are busy with like all kinds of things, and they can't be experts in all of these. They rely on subject matter experts to fill in the blanks, right? So right now, today, if you have that emergency and you call emergency management and they decide to stand up an ESF8 desk, they're going to call public health. So Susan's going to show up, Tiffany's going to show up, Cindy and Patty. In Snohomish County, it's Nancy and Katie. It's those public health people who are very tightly connected with ESF8 who are going to show up for that response. We want to broaden that response pool. We want to give our whole healthcare coalition a role in this response support, and we want to broaden the breadth of knowledge that would be available at an ESF8 desk. So I'll talk a little bit more about that. But this ESF8 resource manual is to be used in support of whomever that person is who's picking up the phone. So right now, the manual consists of about 30 root topics supported by 125 synonyms. So what does that mean? It means that the person who's calling you is really stressed out and maybe not using all of the right terminology, and the person who's answering the phone is also really stressed out and maybe isn't thinking in the best terminology. So if they're calling you to talk about pediatric stuff, you can find that under kids, you can find that under children, you can find that under infants, you can find that under toddlers. And so in this expansive index of essentially a whole bunch of synonyms, when you look up kids, it's going to direct you to the root topic, see pediatrics. When you look up children, it's going to direct you to the root topic, see pediatrics. Infants, see pediatrics. So we're really trying to get down to a core set of root topics that we think might be called by other things, so that whoever's on that phone isn't like, well, I don't see kids. You know, they said something about kids. I don't know where it is. So we're really trying to be thoughtful in developing the proper synonyms for each thing. Like evacuation, you know, might be get out. No, I'm kidding. We don't have get out as part of the index. But, you know, so what are the right synonyms to support these root topics that we want to have in the ESF8 manual? And then the manual itself really, hopefully, isn't going to be much more than a really massive index. We're not trying to recreate the wheel. We're not trying to get every single plan that's in existence into this one big, huge manual. That's a total waste of time, and it's really dangerous because then we have outdated plans in there. We have all kinds of weird redundancy, and we're not interested in doing this. Think of this as sort of, I've been thinking of it as kind of like a trampoline. So you're going to say pediatrics, and you like jump to the pediatrics trampoline, and then it's like, call this subject matter expert, or go to this agency, or see this plan. It's not like you're going to go to pediatrics and there's a 30-page section on pediatrics, right? That's not what we're doing. It's a jumping off point to direct you to the subject matter expert, the plan, or the agency who deals with that particular root topic. So now is there's a bit of a double entendre here. Who will you answer the call? So my call to action is, are you willing to be part of this ESF8 response team? Will you actually physically answer the call at the ESF8 desk when it comes in? So Nancy and Katie mentioned earlier, it was basically the two of them who took the brunt of this response at their emergency operations center. We want to develop really a group of trained volunteers from our whole region who are trained to this manual. It doesn't mean that you're experts in everything on response. It doesn't mean that you're experts on evacuation. It means that you're experts on using this tool so that when the call comes in, you know where to find the resource that they need. You know what call to make. You know what person to get on the line. And we want to do that with some really thoughtful and in-depth training over a series of the next year, I guess, at bringing in more and more people. So our first Emergency Support Function 8 response manual training is on November 6th. It's 9:30 to 11:30 right here in this room. And I'm putting out the call to action today. Oh, and here's a hint. If you're from a clinic or from long-term care, I'm totally talking to you right now because who's who's going to be making those calls? Seriously, if it's a big emergency, it's the hospitals who are going to need us to support them. It's the medical examiner who's going to need us to support them. Clinics, long-term care, adult family homes, you're not going to be as immediately directly impacted, but this is where you can see yourself in response. If you're sitting there wondering, yeah, this is the healthcare, especially the new faces in the room. Yeah, I'm at the Healthcare Coalition, but like, so what? You know, I don't really get it, and maybe they've got a plan template to share with me, but where am I really in this? You're right here. This is what it's about. Are you willing to serve on this team to answer the call when it comes into the ESF8 desk? Are you willing to be at least on the call list, to get the training and at least be on the call list, right? I want 30 people on this call list. I want 50 people on this call list. So we start at the top and we say, hey, Joe, can you come in? Sorry, totally can't come in. No problem. We go one down, right? It's not, you're not promising that you're going to show up if there's an emergency. In fact, please don't. Don't call us, we'll call you sort of thing, right? So if there's an emergency, we will use our call list to get in touch with you. If you're willing to come in, you're going to show up, you know this book, you start taking the calls, you're part of the response, and it's important and we need you. So please consider taking this training on November 6th. It's a 2-hour commitment. It's right here in this room. It's going to be totally fun. And we're going to follow it up later with, we've talked a lot today about EOC's Emergency Operations Center. Our County Department of Emergency Management prefers the term Emergency Coordination Center. So we will follow this response manual training up with one more training to our Emergency Coordination Center at our Department of Emergency Management. So like Katie and Nancy mentioned, they had exercised at their county's EOC. They had like this nice table with 4 chairs and this other table, and we want to exercise to that environment. We want to exercise to the place where you'll actually show up and answer the calls and be working so that you know what it looks like and how it functions. But initially, it's the training on November 6th. You can email hcc@srhd.org. It goes to me, it goes to Travis, and we will let you know more about the training on November 6th, which you should totally show up for. That's it. I'm going to turn it over to Ed. No. Is there another agenda?
Hang on there. Want me to show you?
I have more to say.
Yeah.
I'm sorry. Different topic. This is the last time you will have to endure me at this meeting. At this meeting. Yes, right. So the last agenda item is we want to really have stories from Healthcare Coalition members, very brief, at each of our Healthcare Coalition meetings. And so I'm wondering if, and again, you don't have to raise your hand, come talk to me after the meeting or send me an email right there, hcc@srhd.org. We want to have really brief presentations from our members. Did you write a plan recently? Did you use a plan recently? Did you have some kind of response? Did you think you were having a response because something was going on, so you stood up your emergency operations plan but then realized you didn't need it? That's totally valid, right? That's a real thing that happened. So we want you to think about, yeah, how are we participating in this work, and how can we share those stories with other people? We'd like to have 1 or 2 or 3 at each of our meetings. 5 minutes, just tell us where you're at, what you're up to, what your challenges are, what your successes are. So please think about that. Really want engagement from our members in the work that we're doing. Now I'm done. For reals.
Thanks, Eric. Well, that pretty much concludes what we wanted to talk about today. I guess maybe just a couple thoughts that I have. Nancy and Katie, thank you very much for your presentation. A lot of great information, a lot of lessons learned, and I think for me, a lot of things that we've talked about, a lot of things that we're working on, maybe kind of raise the priority level on some of those based on what they've experienced, and thinking, yeah, maybe we need to spend a little more work there than what we're really spending based on lessons that they've learned. And you know, it's really not nice to say, but I really like to be able to enhance what we're doing based on the lessons that other people learn instead of what we've learned here. So it's a great opportunity to capitalize on experiences that people have had to go through and what it really means, not only to their community, but to them themselves and to their agencies to be able to do that. I think Erica's last point here about, you know, bringing people that want to talk to us as a coalition about what you are and who you are is really critical, because And Katie also made the comment about she never looked at her plans. Well, I've been involved in the coalition and this effort since the inception, and Mr. Dave Burns probably gave us the most knowledgeable information, which probably is unofficial, but it's something that he preaches pretty solidly. And that is that the plans really aren't the value to what we're doing. The plans that we're developing are about building the relationships and understanding who you're working with and what capacities they bring to the table. And Katie didn't have to grab those plans to know what she needs to do because she knew who was out there and what they could do and how to do it. And so really, this is where the value comes in, is us learning who we are and what we are and how we work together, what we can offer each other, and what we can expect to receive. That's the value in this coalition and what we can bring. So just to have you here is a great initiative. Just I wanted to point out another thing that Katie and Nancy had talked about was, and we've heard about this at every experience and presentation that we've had, and that's the piece around the mental health piece and the behavioral health piece and how critical it is and how it's always usually an afterthought to a response. And I think something that we're pretty proud of, or at least I am, and I wish Jan was here because she should be as well. We got asked for a deliverable at one point to include mental health in our planning. And so as Katie did when somebody said, give me a mental health plan in an hour, we kind of looked at each other at that coalition table, for those of you that were here, and think, what's that? We don't know what that is. So we had to ask Jan to give us a little paragraph to put into our plan, our regional plan. She didn't give us a page. She gave us a plan. She worked through a behavioral health response plan, drafted it, worked with our partners to make it work, and we have a plan that in any community in our region, if they need mental health providers, they pick up the phone, they call the RSN as the contact. The RSN will work with us to dispatch mental health providers throughout our region, and that is just awesome. So it's just an example of what our partnerships can do as we work together. So let's thank you for being here today. Thank you for being involved in the conversation. And I hope and I'm excited and look forward to working with each and every one of you as we move into the future. So thank you. Oh, God.
I'm sorry. I have one more thing to say. I mentioned our state Watch Track employees are here, and they're going to be here for about an hour after the meeting today. If you want to learn about Watch Track, see Watch Track, get some training, ask a question, please stick around. We'll be here till about 3:30. That's it.
And just on my final closing note, I would like Erica to stand up again, because I would like to say
Stood up enough today.
Thank you very much for your 4 years that you've provided. I can honestly say that Erica and I don't always agree. Erica usually wins, but it really turns out pretty well. So thank you, Erica, for your time.
Thank you, and I just want to, it just occurred to me that I think maybe, again, so many new faces in the room, you might not realize how lucky this region is. You're so lucky to have me. It has nothing to do with me. You're lucky that the leadership of this coalition prioritized years ago that they think it's important to have a person to move this work forward. Ed mentioned it earlier today. We are unique in this state, with the exception of now 2 combined counties, but one healthcare coalition who is like a staff of, how many staff do you guys have? A lot. 10 staff in the King and Pierce County Combined Healthcare Coalition, which is a standalone nonprofit organization. With the exception of that coalition, we are unique in this state that we have a dedicated full-time person working on healthcare coalition stuff. So it's not about me, it's about the leadership who decided that, and I just think that's so lucky for everybody here, and it might not be something you know, so I just wanted to make sure you knew that. I'm done again.
No, you're not. So I'm going to quiz Erica here real quick. Erica, on October 16th, what is happening?
Our Healthcare Emergency Preparedness 101. So we hold an annual event where we try to get new healthcare providers into our healthcare coalition. So basically, if you're in this room today, this event is not for you. You already get it about the healthcare coalition. You're already here. What we want to do is have you invite your other healthcare provider partners the other clinic down the street, the other long-term care facility down the road, the person you met at that conference last week. Tell them about the Healthcare Coalition and encourage them to come to Healthcare Emergency Preparedness 101. So we're talking about what the Healthcare Coalition is, why we're so awesome, why it's so important for every size of healthcare provider to be engaged with the Healthcare Coalition, and they can learn more by emailing hcc@srhd.org.